Hello, Assalamu alaikum. I am Dr. Firoz. Welcome you all from my Facebook page, Mediscope MRCS. So, hope you all are fine. Our today's topics is knee pain, its causes and differentiation. It is a very important topic for MRCS Part A, and maybe 2 to 3 questions can come from these topics. So, let's begin. At first, we should know what are the common causes of knee pain and how to differentiate these causes as a responsible one. So, at first, we can group the causes of knee pain in adults and in children. So, in adults, there are some causes including anterior and posterior cruciate ligament injury, medial and lateral collateral ligament injury, meniscal injury. And other than these, there may be fracture of patella, dislocation of the patella, chondromalacia patelli, and tibial plateau fracture. And in case of children, four causes are important: developmental dysplasia of the hip, Perthes disease, slipped upper femoral epiphysis, we can call it as SUFI. And last one is Osgood-Schlatter disease. So we should find out the exact clue or key points that helps us to determine the correct answer. So, at first, before entering the main topics, I would like to discuss the ligaments in a very short terms. The anterior and posterior cruciate ligaments are responsible for antero-posterior stability of the knee joint, and two collateral ligaments including medial and lateral are important for side to side stability of the knee joint, and meniscus are mainly involved in the movement of the knee joint. So at first I like to discuss regarding the mechanism of injury. All the ligaments and meniscal injury are mainly occur in the sports related event. So what are the key points in the ligaments and meniscal injury? Let's see. In case of anterior cruciate ligament injury, they will give a scenario that a football player or other player in mainly in the contact sports like football, or it may be rugby. So there is suddenly the player during landing or during playing, there is a twisting force applied to the flex knee, and he heard a loud crack, and there is rapid swelling of the joints, and he was unable to continue the play. So here is the key point is twisting force applied to the flex knee, and there will be a loud crack and rapid joint swelling. So all these clue points are indicative of ACL injury. In case of posterior cruciate ligament injury, there may be a term that is hyperextension injury. So when the knee is extended and if there is applied a force that causes hyperextension, it may cause PCL injury. And medial collateral ligament injury, in case of this, there is a force applied on the lateral side of the knee, or may be called that leg forced into valgus position. We know that there is two position of the knee, one is valgus position and one is varus position. In valgus position, the leg is forced laterally. We can see the picture. The third picture is valgus position. That means there is a force applied on the knee joint from the lateral side or from the outside. It causes stretching of the medial collateral ligament, and it may also causes the tear of the medial collateral ligament. And in case of the opposite scenario, when a force applied from the medial side of the knee joint, it can causes injury to the lateral collateral ligament. Okay. So, in case of MCL injury, leg forced into valgus position. Next, meniscus injury. In case of meniscus injury, there may be a force that is rotational or twisting applied to the knee joint. That means in case of ACL injury and in case of meniscus injury, the clue of force is more or less similar. Okay. Other causes of knee pain that may include patella fracture, patella dislocation, chondromalacia patelli, and tibial plateau fracture. So, in case of patella fracture, two causes may be important. One is direct blow and another is avulsion fracture. And avulsion fracture means if there is a severe contraction of the quadriceps muscle, it may fracture patella, a part of patella that is attached to the quadriceps tendon or ligamentum patelli. This is called avulsion fracture. So, in case of patella dislocation, the same causes as in patella fracture are responsible. One is trauma, one is quadriceps contraction. Next topic is chondromalacia patelli. In case of chondromalacia patelli, the two keywords may given. One is teenage girl, teenage sports girls, and it occurs following an injury to the knee. So keep in mind that teenage girl related to chondromalacia patelli. And last one is tibial plateau fracture that mainly occurs in the elderly, or it may also occur in young in case of traumatic event. Now, here is the differentiating flowchart. In the question, if you found there is stated that there is joint swelling, how could we differentiate the cause? One is, if they stated that the joint swelled rapidly after injury, there may be two possibilities. One is ACL injury, one is patella dislocation. If they stated that there is loud crack, pain, unable to continue the play, along with rapid joint swelling, the answer will be ACL injury. And if the rapid joint swelling is associated with clinically obvious displacement of the patella, it will leads to the answer to patella dislocation. So rapid joint swelling have two causes. One is ACL injury, one is patella dislocation. Next, if the joint swelling is delayed with previous history of trauma, and they also stated that there is knee locking, then our answer will be meniscal injury. And there may be also other clue points such as recurrent episodes of pain and effusion after minor trauma. So the causes of delayed swelling will be meniscal injury with history of trauma and knee locking. And another scenario may be asked in the exam, that is the patient have knee locking with no previous history of trauma. Then the cause will be a loose body of the knee that occurs in osteoarthritis. So if there is knee locking with history of trauma, the answer will be meniscal injury. If there is knee locking with no history of trauma, the answer will be osteoarthritic loose body of the knee joint. So here is some other presentation in case of PCL injury. There may be another key point that tibia lies posterior to the femur. That means the alignment will be lost, and there is obvious that tibia seems to lie posterior than femur. And in case of MCL injury, knee become unstable when put into valgus position. And last one, in case of chondromalacia patelli, we stated that it occurs in the mainly in the teenage sports women or sports men with history of trauma. And here is some others clue point, that pain on going downstairs, or it may also occurs at the rest, and there may be tenderness in the knee joint, and there also may be quadriceps wasting. All these are indicative of chondromalacia patelli. Okay, we already seen this picture. Okay, there are in case of patella dislocation, there are three risk factors. Just to see the slide, not very important. The risk factor includes genu valgum, tibial torsion, and high riding patella. So sometimes in question they may told that the patient have one of these risk factor and stated some clinical scenario that is indicative of patellar dislocation. Okay, tibial plateau fracture is really not so important for the exam, but I included it in this picture just to see, just to take a look once. Okay, so what are the clinical signs that may be posted in the question? In case of ACL injury, two tests may be positive. One is Lachman test and another is anterior drawer test. In case of PCL injury, two tests here, also two tests is positive. One is posterior sag sign and posterior drawer test. In case of MCL injury, valgus stress test will be positive, and in case of meniscal injury, McMurray test will be positive. Details of these signs are important in MRC's Part B exam. Here only memorizing the names are sufficient, as sometimes in questions they exclude a DD by giving like that the McMurray test is negative or valgus stress test or varus stress test is positive or negative, and they can lead us to a particular answer. Okay, next, knee pain in child. Knee pain in child is very important, as because at least one question must come from these topics. Okay, at first, developmental dysplasia of the hip or DDAs. It is a congenital anomaly in case in child that is usually diagnosed in infancy. It may be bilateral or unilateral, and if the condition is unilateral, there may be a leg length shortening on the affected side. In case of bilateral, there is defect in both sides, so there will not be any leg length inequality. Okay, and the usual presentation is they will say that patient have antalgic gait or patient may limp, and there may be early onset arthritis, and another clue point may be given that there may be an extended breech presentation in intrauterine life, and last one is important, there may be an abnormal skin creases in the groin of the child. So all may be the clue point. Mainly important is limping, history of extended breech presentation, and abnormal skin crease in groin. So they may ask the diagnosis and may ask the investigation, most important or most obvious investigation or most definitive investigation after giving the clinical scenario. So in case of diagnosis, Plain X-ray, initially there may be no obvious change, and ultrasound, uh, if they ask a definitive investigation and stated that the infant is under 3 years, what is the best investigation? The answer then will be ultrasound. It gives best resolution until 3 months of age, and if given that the infant age is more than 3 months, then ultrasound will not be the answer. Okay, in case of plain X-ray, initially no obvious change may be seen, and Shenton line should form a smooth arc. So what is the Shenton lines? Let us see just a while. Shenton line is formed by the outlines of the upper margin of the obturator foramen and the inner margin of the neck of the femur. So, Shenton line in normal person should form a smooth arc like the green line connecting the upper margin of the obturator foramen and inner margin of the neck of the femur. But it may be disrupted in two conditions. One is DDH and another is hip dislocation. So, diagnosis of DDH is mainly by plain X-ray and ultrasound. What are the treatment options? Just for reading once, we can use splint and harnesses or traction. In later years, osteotomy may be needed and hip realignment procedure may also be considered. And if there is arthritis, joint replacement may also be needed. Okay, so next topics. There are two very important topics. One is Perthes disease and one is slipped upper femoral epiphysis, that is SUFI. In both conditions, the hip pain is referred to the knee. So how can we differentiate? One is age. In Perthes disease, the typical age is between 5 to 12 years. And in case of SUFI, after 12 years, and the most important keywords is obese male adolescents. If you see at the start of the question that there is obese male adolescent, you can certain that the answer will be SUFI. So what are the other features? In case of Perthes disease, X-rays show flattened femoral head, and eventually femoral head will be fragmented in the later stage. Let's see the picture. It's a X-ray of the hip. Here it is shown that the femoral head is not in its rounded contour and it is becoming flattened. So it is a picture X-ray of Perthes disease. In case of SUFI, there may be other keywords like limitation to internal rotation, and knee pain is usually present 2 months before the hip slipping. So let's see the SUFI. Here is the X-ray of SUFI, and in right side of the hip, you can see that femoral head is displaced inferior inferiorly. It's like a melting of a cone ice cream. They told that. Okay. So in case of Sufi, what may be the key point? Knee pain usually present 2 months prior to hip slipping, and X-ray may shows femoral head displaced and falling inferolaterally like a melting ice cream cone. So with this differentiating point, we can diagnose the Perthes disease and Sufi. Treatment of Perthes disease may include it is usually self-limiting, and if diagnosed and treated promptly, that means early diagnosis may lead to early healing. Other than that, we can give physiotherapy and remove pressure from joint to allow normal development. There is a staging system for Perthes disease. I will discuss this staging and Perthes disease in details in later presentation. Here only a summary. There are 4 stages. In stage 1, there is only histological and clinical features only, but there is no radiological findings. In case of stage 2, there is sclerosis with or without cystic changes and preservation of the articular surface of the femoral head. So, in case of stage 1, clinical and histological features, stage 2, sclerosis. Stage 3, loss of structural integrity of the femoral head, and stage 4 is characterized by loss of acetabular integrity. Okay. Treatment of Sufi includes bed rest and non-weight bearing, and here our aim is to prevent avascular necrosis of the femoral head. And if there is severe slippage or risk of slippage, we should consider an option, that is percutaneous pinning of the hip. Okay, that's all about Sufi. And last one is Osgood-Schlatter disease. The disease also present with knee pain that is worst during activity and settles with rest. It will be the key point. And on examination, there is tenderness overlying the tibial tuberosity, and there may be associated swelling at that site. So, the key point will be worst during activity, settles during rest, tenderness overlying tibial tuberosity, and associated swelling. Treatment is conservative with cold compression. Okay, that's all about knee pain and differentiation. And let us see some question. Number 1 question: an obese 12-year-old boy is referred with pain in the left knee and hip. So, hip pain, knee pain. Obese 12-year-old boy. On examination, he has an antalgic gait and limitation of the internal rotation. His knee has normal range of passive and active movement. What is the most likely diagnosis? All the features are similar with Sufi. So our answer will be number E, slipped upper femoral epiphysis. So here is the key point: is obese 12-year-old boy. Antalgic gait, limitation of the internal rotation. So answer will be Sufi. Next question. A 19-year-old sportswoman present with knee pain, which is worse on walking down the stair and when sitting still. On examination, there is wasting of the quadriceps and pseudolocking of the knee. What is the diagnosis? So here is the key point is teenage sportswomen that is consistent with chondromalacia patelli, and also there is walking the pain worse on walking down the stair. It is also a key point, and there is also wasting of the quadriceps. All indicate that the answer will be chondromalacia patelli. Okay, so next question. A 5-year-old boy present with a painful limb. The symptoms have been present for 8 weeks. Two hip x-rays have been performed and appear normal. What is the best course of action? If uh, if stated that x-ray is normal, what is the next definitive investigation you would like to do? The answer you should select with your closed eye, that will be MRI, not CT. If they stated that MRI is not unavailable or in the question there is no option for MRI, then go for CT. So in these cases there the answer will be arrange a hip MRI. Okay. Next question. An 8-year-old boy present with symptoms of right knee pain. The pain has been present on most occasions for the past 3 months, and the pain typically lasts for several hours at a time. On examination, he walks with an antalgic gait and has apparent right leg shortening. What is the most likely diagnosis? So we know that leg shortening, causes of leg shortening may include DDAs, or in case of Perthes disease, if the femoral head is becoming flattened or fragmented. If and here they stated that the age of the boy is 8 years, so we can exclude the DDAs, and DDAs is not also in the answer, so our answer will be Perthes disease. Okay, next question. An athletic 15-year-old boy present with knee pain of 3 weeks duration. Athletic 15 years old boy. It is worse during activity and settles with rest. On examination, there is tenderness overlying the tibial tuberosity and an associated swelling at the site. What is the diagnosis? It is a straightforward question. The answer will be Osgood-Schlatter disease, as because there is tenderness overlying the tibial tuberosity and associated swelling. Okay, next question. Which of the following statements relating to the meniscal tear is false? The number one A is medial meniscus is most often affected. It is true. Medial meniscus is more often affected than the lateral, as because lateral meniscus is somehow is protected, more protected than medial. True locking of the knee joint may occur in case of meniscal tear. It is also true. Most established tear will heal with conservative management. When the tear is already established, it will not heal by conservative treatment. It will need some intervention. So the answer will be number C. Let's check the D and E. In the chronic setting, there is typically little to find on examination if the knee is not locked. It is also true in case of chronic condition, there is usually no symptoms. And last one, an arthroscopic approach may be used to treat most lesion. It is also true. So the answer will be C. Okay, next question. An obese 12-year-old boy present with knee pain. On examination, he has pain on internal rotation of the hip. His knee is clinically normal. What is the most appropriate investigation? So, 12-year-old boy with knee pain. Knee is clinically normal. What is the most appropriate investigation? Okay. So, as because the knee is clinically normal, so we should consider the pathology in the hip joint. So X-ray, I think X-ray will be the most appropriate investigation in that case. So hip X-ray, number D will be the answer. And please remember the pelvic X-ray will not be the answer. The answer will be hip X-ray. Next question. A 34-year-old woman is a passenger in a car during an accident. Her knee hits the dashboard. On examination, the tibia looks posterior compared to the non-injured knee. Which structure has been injured? It is a typical findings in posterior cruciate ligament injury. So the answer is straightforward, number B. Next question. A footballer is sustained a knee injury in a match and is being assessed in the outpatient department. On examination, he has a positive valgus stress test and minimal joint effusion. What is the most likely underlying injury? We know that positive valgus stress test indicative of medial collateral ligament injury. So the answer will be B. Next, a 6-year-old boy present with groin pain. 6-year groin pain. He is known to be disruptive in class. Disruptive. He reports that he is bullied for being short. On examination, he has an antalgic gait and pain on internal rotation of the right hip. What is the most likely diagnosis? So here is there is limb length shortening, antalgic gait, pain on internal rotation of the right hip. So I think the answer will be Perthes disease, as because a 6-year-old boy, so there is flattening of the femoral head. So it is the result, it is the cause of the antalgic gait and limb length inequality. So answer will be Perthes disease. Last question. A tall 18 years old male athlete is admitted to the emergency room after being hit in the knee by a hockey stick. So direct trauma. On examination, his knee is tense and swollen, but X-ray show no fracture. What is the diagnosis? Diagnosis. So knee is tense and swollen, but there is no fracture. So I think the answer will be dislocated patella. As because there is two option, one is patella fracture and one is dislocation, and they give the clue that X-ray show no fracture, so the answer will be dislocated patella. Okay, here is all about the knee pain and its differentiation. If you have any inquiry, feel free to contact with me. Okay, thank you everyone. Best of luck.